Hello, everybody. We're just waiting on some more folks to jump on. Give it a couple of minutes here and we'll get rolling.
Hello.
All right, everybody. We're still waiting on a couple more to jump in here. And we'll get going here in just a minute. Appreciate you guys jumping on today for this talk with Dustin, and hopefully you find it useful. All right, I'm going to go ahead and get going, Dustin. It's the top of the hour. Thank you, everybody, for joining. My name is Brett Schaefer. I'm the field marketing for Axonics. I work alongside Dustin for this great fit to offer. Dustin's going to kind of go over everything today. There will be, I just ask you guys to mute yourself if you haven't already done so. That way, background noise. There will be, you will have the ability to type in questions into the chat box down below. If you have any questions throughout the webinar, just feel free to type those in and we'll have Dustin answer those. So I will be launching a poll towards the end with 3 questions, just saying if you found this helpful or if you want more information, Dustin can get that to you as well. So anyways, without further ado, I'm going to go ahead and pass this off to Dustin. I'm going to share my screen, Dustin, and we'll get going.
All right. Thanks a lot. And thank you guys for joining us. The purpose for doing these webinars is it's a kind of an educational opportunity for everyone to learn more about certain diseases and illnesses that we treat here at NAU and talk about some new treatment options that have been going really well. These things, we don't have this much time in a visit with each patient to talk to. So this allows us to set aside some time and go into things in more detail.
Awesome. So Dustin, can you see my screen?
I can, yes, sir.
Okay, let me go ahead and put this in transition and we'll get rolling. Slideshow. All right. All right, everybody. We're going to go ahead and pass this off to Dustin to get this thing kicked off. And Dustin, the floor is yours.
All right. So like I said, we're going to just kind of do a brief overview of overactive bladder and all of the current treatment options, and then go a little bit more in detail to what the Axonics treatment option is. Just a little bio about myself. I have been with NAU for about 7 years now, doing all sorts of urology. I do a lot of male urology and as well as female urology as well. So as we all know, bowel and bladder symptoms can definitely disrupt your life. You know, patients that I generally refer to as bathroom mapping, where as soon as you get to a restaurant or something like that, the first thing you do is sort of identify where the closest bathroom is. And it can interfere with things like trying to go on long road trips with families and many other things. So definitely a quality of life impact for sure. You're definitely not alone. We treat all kinds of patients for this. 50 million people in the United States, pretty huge number. And only half of those with severe symptoms seek treatment. So again, yet another outreach we're trying to do, just to reach out to people, let you know, definitely not alone. And there's absolutely excellent treatment options out there. So these are kind of the 3 main areas in which what we would call an overactive bladder, or these sort of urinary incontinence, urinary frequency symptoms fall into. So you have overactive bladder, which is that sort of sudden urge to urinate and unable to hold or control it. So really the really defining factor there is the urgency. Whereas when you feel the need to go pee, you're like, I got to go right now, and have very difficult trouble holding it. There's urinary retention, which is sort of the opposite end, and that's where you have difficulty emptying or completely emptying your bladder. And then there's fecal incontinence, which we'll talk a little bit about that. Obviously, in urology, we don't deal a lot with it, but some of the treatment options we do offer can help with that as well. So this is an overview of normal bladder function. So the way our bladder generally works is that it is covered in a muscle and it fills with urine that's produced from the kidneys. Once that bladder is filled to a certain point, we have these sort of receptors in the bladder. They're called stretch receptors. So as the bladder expands and stretches, then that signal fires up to our brain that says, hey, you need to pee. And that's the normal functioning bladder. So with overactive bladder, what's happening is that your bladder is signaling to your brain that you need to go pee before it is actually full. So I call these sort of these premature, nerve signals that are firing up to the brain. So the bladder may only be, 20% full, but for whatever reason, your bladder is telling your brain that you're 100% full and that you need to go pee. These are just some other definitions. Urinary frequency, so we usually define that as 8 or more times a day. The urgency, I talked about that. That's that I got to go right now, hard to control. And then, of course, the involuntary loss of urine is incontinence and nocturia. So the nocturia is the waking up in the middle of the night to go pee. One time we consider normal. Anything more than once a night is considered abnormal. And obviously, that's going to affect your ability to get a good night's rest as well. So we kind of talked about that, what happens with overactive bladder. It's that abnormal communication between your brain and your bladder. So your bladder is telling your brain that you're full and you need to go pee, but you're really not full. So talking about urinary incontinence. So there's two, I guess really three. So there's stress urinary incontinence, which this is what happens whenever you leak a little bit of urine when you cough or sneeze. And this can be due to a number of things, usually due to weak pelvic floor muscles. Women a lot of times experience this after childbirth, after the ligaments stretch. And then there is what we call the mixed urinary incontinence. So that is the urgency urinary incontinence, which is, I got to go pee. I got to go pee. Oh my gosh, I can't find a bathroom in time. And then you leak a little bit. Okay, so that's what we call OAB wet, or the urgency urinary incontinence. You have that sensation you need to go pee, you just can't make it in time. And then mixed, obviously, is where the two overlap. So that's where you have both the stress incontinence and the urgency urinary incontinence. We call that mixed urinary incontinence. Normal bowel function. So again, the bowels are very similar to the rectum. The bowels work very similar to the bladder. The rectum fills with stool, stretch receptors are fired, tells your body, hey, I need to go have a bowel movement. Pelvic floor muscles relax, you have a normal bowel movement. That's the normal function of the bowel. Fecal incontinence is exactly what it sounds like. So that's where you are losing some fecal matter, whether it's because, again, it mimics just like the bladder, whether it's because of you feel that you need to have a bowel movement, you can't make it in time, or you just leak stool. This isn't an issue we really deal with in urology, but again, some of the treatments that we do offer can help with both. And just this slide here is just talking about, obviously what I kind of touched on, how it impacts your quality of life. I mean, most people that experience these symptoms, we don't really need to tell them these things, but obviously reduce social interactions, you're not wanting to go out and do things. You don't want to go to movies because you got to get up all the time. And then of course, wearing the protective undergarments, people don't like that. They don't like the special bedding. Avoiding sexual contact and intimacy, that one's really big. We see a lot as well. So many aspects of your life that it affects. Not a normal part of getting older, not just part of being a woman. And we treat just as many men with this condition as we do women. So for the women out there, don't think that this is just a female problem. It's absolutely not. Just an issue with the prostate, again, not necessarily the case, and definitely not caused by something you did. So good news. Yep, there are treatments to help you regain control of bladder and bowel, and we're going to about to highlight those here just a second. So these are called the care pathways, and you'll see a lot of them start out the same. Obviously, the consult with your doctor. Here we basically do some general baseline tests. Many of you watching this have probably already done a bunch of these. We check your bladder residual after you go void. We have you do a bladder diary where you record, how many times you're going to the bathroom, how much you're going, and at what times you're going, and as well as measuring your intake as well. Some of the initial treatment for overactive bladder, we do bladder training exercises. This is generally in conjunction with pelvic floor physical therapy. We're sort of using biofeedback to allow your body, or your mind rather, to sort of ignore that first urge. And then sacral neuromodulation, one of the more advanced methods of treatment, as well as the PTNS and Botox. And we'll go into a little bit of detail on those as well. Urinary retention, again, still starts the same, doing really the same exact test that we did before. The difference is initial treatment in men, we generally will start with some medication to help relax the prostate so that they can empty their bladder better. And then moving on from there, the sacral neuromodulation. Sometimes we require self-catheterization, then many times surgery to sort of debulk the prostate is warranted as well. Fecal incontinence, similar initial treatment. Again, this isn't really a area that we focus in on. This would be more of your gastroenterologist, but similar, starting out with consulting the doctor, going through the baseline test, and trying conservative therapy before moving on to some of these other more invasive therapies. So going in a little bit more detail into the initial treatment for overactive bladder, the bladder training exercises, like I mentioned, this is mostly in conjunction with pelvic floor physical therapy. Lifestyle changes, so monitoring fluid intake. Obviously, if you're drinking excessive amount of fluid, then that can cause an excessive amount of urination, as well as trying to figure out what your bladder triggers are. For some people, they're alcohol. For some people, they're caffeine. Everybody's a little bit different. There are a couple of prescription medications we use. Some of them promote the bladder relaxation, so we're helping relax the bladder so it's not so contracted. And then other ones are blocking detrusor contraction. So just medications to help slow the bladder down so that it's not firing so frequently. So these are some advanced therapies for OAB. So I mentioned PTNS. This is percutaneous tibial nerve stimulation. This is kind of an interesting treatment. We use a little tiny acupuncture needle into right above the ankle. It's the it's the tibial nerve. And we basically send a little electrical current up through there, and it's sort of stimulating the bladder. We do 12 weekly sessions, about half an hour each. And this is a treatment that does require maintenance, however. So if you do see improvement after the 12 sessions, we do have to do maintenance about every 6 months. Botox, another advanced therapy for OAB. Just like the Botox you think of when you think about cosmetic procedures, we do this, it's the same exact Botox, except we're injecting this into the bladder wall. This is done in an in-office procedure, also can be done in the hospital as well. However, this is a procedure that absolutely will have to be repeated about every 6 months. Sacral neuromodulation therapy. So this is kind of what we're here to talk about today. This therapy uses similar to the PTNS in that we do provide an electrical current to the nerves that feed into the bladder. And it helps just sort of quiet down that noise that's going up to the brain. We do it as a trial here in the office to see if it is going to work for you before we put the permanent implant in. And we'll go into much more detail about that here in just a minute. So what is Axonics Therapy? So it's indicated for both overactive bladder, urinary retention, and fecal incontinence. So it can actually help with all three of these issues. So the way it works is it's a little implant. So think of like a little, I don't know, to me it looks like a little flash drive, but it's about the size of a quarter. And it's implanted just underneath the skin. It has a battery in it. And then we have two wires that come off. And these two wires go right into your tailbone, into the nerves that, like I mentioned, feed into the bladder. And it's really designed just to restore that normal communication between the bladder and the bowel. You don't feel anything. It's not a impulse that you necessarily feel, but it does happen. It does start to work immediately and sort of quieting down those contractions. So the first step is doing the trial. So the trial we do here in the office, it takes about 30 minutes. We give you a little medicine through an IV to help relax you. We put two wires down in your lower back. Those are guided into your tailbone. And then we'll tape a battery pack on the outside. You'll wear this for a couple of days. You'll have a little remote that you can adjust the stimulation on, and that allows us to see if this treatment's going to work for you. Fortunately, it starts reducing your symptoms right away, so this isn't something you have to wear for a few weeks or something like that. Usually, a couple of days is all we need to determine if it's going to be right for you. So there's an idea of the size of that. Now that's the permanent implant that goes in. It's minimally invasive. When we do the permanent implants, those are done in the operating room. Very short procedure. As you can see there, it's extremely small. It goes right above your hip on your back through just a little tiny incision. They are designed to last for at least 15 years.
Wow. Wish mine was.
The really nice thing about the implant is that they are made out of ceramic and titanium, so you can still get MRIs. Some of the other older implants that are made out of other types of metal, they are not MRI safe. However, this is safe for MRIs. You do get a little remote control, which I think is super cool. It will tell you when your battery's getting low. And it also allows you can completely turn off the stimulator if you want to, and it also allows you to adjust the stimulation. So if you feel like your symptoms are waning a little bit, you can increase the intensity. Another thing that's pretty neat, this implant compared to some other previous older models, is that it has a constant current technology, so that over time, as scar tissue develops, if we just keep the current the same, it's going to decrease. However, this device can detect the impedance, and it will actually increase the current to adjust for any scar tissue buildup. So how do you charge it, right? So great question. So most patients I find are charging theirs about once a month. It is a wireless charging system, so much like the newer cell phones now. You don't plug anything in. A disc there's a little Velcro belt that you'll wear, and you basically just line up this disc right over top of where the implant is. Your remote will tell you when it's charging, and once it's fully charged, it'll tell you that as well. Usually takes about an hour. And again, you're only doing this about once a month. Some patients even every 2 months, depending on their intensity level. So these are just some survey questions that they asked patients that were getting them, just to show you that most patients were, thought that it was extremely easy to charge and wear the device. Not complicated at all. And again, it's not something you're doing every day. So again, just some more statistics on results. 93% of patients achieved clinically significant improvements in incontinence symptoms at 2 years. Now, that doesn't mean it takes 2 years to get those results. It just means that 2 years later, they're still seeing the same results as they did when they first got it in. 94% satisfied, and 93% would undergo the therapy again with the same expected results. So great statistics. And I would say for our practice, I think only maybe 1, maybe 2 patients have undergone the trial and then not gone through with the full implant because it just didn't work out. So the vast majority of patients who, after they do the trial, do go on for the full implant. And it's been pretty amazing, the results we've been seeing. So getting started, like I mentioned, is really just getting set up for the trial. We are doing these about once to twice a month. So we set them all up kind of on one day. So if you are interested, we just need you to let your provider know, whoever you're seeing at our office, or if you're not seeing anyone at our office, then schedule an appointment, and we can let you know if we think it's a good fit for you.
All right, Dustin, I'm going to come off mute, and we've got a few questions here in the chat. We're going to kind of hash these out. For the audience members, I did launch a short 3-question poll that if you would be so kind as to answer those questions and let us know your feedback, and if you'd be interested in learning more about the therapy and how it could work for you, just let us know in that poll. So with that being said, I'm going to go ahead and turn to the first question that we have and say, how well is this covered? How well have you seen this covered from an insurance standpoint, Dustin?
Yeah, I mean, I'm not too much on the billing side. I try to stay as far away from that as possible, but I've not seen any kickback at all from insurance, from both Medicare and commercial payers. None of my patients so far have decided not to do it because of a coverage insurance issue. So, of course, everyone's going to have their own individual deductibles and things like that we have no control over. But for by and large, this is a insurance covered procedure.
Sure. The next question is, what's the limitations throughout the trial stage? What are they?
Yeah, that's great. So you do have to be really careful during the trial because these leads are just taped in. The permanent leads actually have little tines on them to keep them from migrating, but these are not. These are simply slipped in. So we want you to be careful with, bending, stooping, leaning over. Obviously, you're not going to be doing any kind of physical activity as far as exercise or things like that. You don't have to lay in bed all day. I mean, you can go around and do your day-to-day things, but just be mindful of that. And again, it's only 2 days, so it's not a putting you out for a week, but we do go over all that with you. And you're not laying in bed for 2 days, but we just have to be careful with our movements.
Great. And then what is the timeline for being out of work from the time has the implant done?
That really depends on what kind of work you do. You have to remember that this is really just a minor skin procedure. We're making just a little incision in the skin and dropping this tiny little device in, and tunneling the leads in. So I would say that maybe a few days, especially if you just kind of do a desk job, you might be out for a couple of days, but that's it. There is really no recovery from the actual procedure.
Awesome. That's all I have in the chat box. So I appreciate your time, Dustin, and everybody else for joining today. And as I mentioned, we're going to kind of get this recording put out. So if there's anybody that you think can benefit from, we're going to be sending out via email the ability to do that. So thank you, everybody, for your participation today. And if you have any further questions or would like any more content regarding this therapy and how it may benefit, please don't hesitate to reach out directly to the clinic, okay? Thanks a lot, Dustin. Appreciate it.
Thank you.
Thanks, everybody. Have a good day.